Hello, everyone. My name is Andreas Schulze. I'm a metabolic physician working in the field of creatine deficiency syndromes since 1994, when I identified one of the first patients with GAMP deficiency. And yeah, I'm doing research. I'm a clinician scientist, so my research laboratory works on creatine deficiency disorders and is now very much interested in creatine homeostasis.
Thank you, Dr. Pasquali.
Yes, hi, Marzia Pasquali. I am a clinical biochemical geneticist at the University of Utah and ARUP laboratories. My focus, my lab is specialized in running a test to screen, diagnose, and monitor patients with metabolic disorder. I've been involved with the creatine project, let me call it this way, and developed a newborn screening test that we have implemented in Utah. We were the first state implementing a screening for GAMP deficiency. And I'm continuously trying to come up with newer and more sensitive and specific tests for many metabolic disorders, but creatine deficiency syndromes are at the top of my list.
Thank you, Dr. Stockler.
Yeah, I am a biochemical geneticist at BC Children's Hospital in Vancouver. I'm currently on vacation in Turkey, and I hope that my connection will last. I've been involved with GAMP deficiency since the inception of the whole disease, since it has been discovered in the 1990s, and one of my main interests in my clinical and research career have been creatine deficiency syndromes. I have been working with ACD for the last couple of years on the core outcome set project where we identified the guanidino acetate as a core outcome, of course, for GAMP deficiency. And I'm also working with ACD on a project with creatine transporter deficiency with some drug repurposing. So quite busy. So ACD makes us quite busy. They are very active, and we try to catch up with them.
Thank you. Dr. Thurm.
I'm Audrey Thurm. I'm a child psychologist, a little different in background. I've been involved in creatine deficiencies from the perspective looking at behavior and development in the natural history study, and now involved in both of these PAReNts grants. And I'm very interested in helping us figure out, as we are looking at these levels in plasma, of correlating it with behavior, and certainly over time, as we're going to be looking at change over time with treatment trials. And I'm just glad that this PAReNts grant is moving along. We're at this point. Thanks.
Great. And then I've listed Carrie-Ann, who I think is not able to come. Oh, Carrie-Ann, there you go.
Hi. Hi, I am Karin Basson. I am Mias's mom, and he is a 4-year-old little boy with GAMP. This is his little sister. I'm not sure if you guys can see me. Yeah, so we had some challenges with measuring guanidino acetic acid, and coming from a science background, I had to resort to make it happen. So that's my story in short.
Thank you. And Tony is unable to join. It's the middle of the night for him in Australia, so we have his recorded talk. And with that, I will go back to our agenda. And Dr. Pasquali, did you want to bring up your slides, or would you like us to?
No, I can bring them up. I was able to get them. Okay. Can I share my screen? And let me see which one. Okay. Okay. Now Microsoft, this one. Team. Okay. Oh, sorry. It's
I think Dr. Schulze said he had them if you want him to present.
yeah, I don't know what if it might be better because there are the security. It's not gonna let me share.
Okay.
Yeah, it might be better if someone else share the slides. Yeah, that'd be great. Thank you. I apologize.
Are
but
these the ones, Marzia?
yeah, these are the one.
Okay, I can advance them if I don't have to answer the phone.
Yeah, and I don't know, Heidi, you were showing a blood plasma collection, and these are the slides for the conference. So I don't know, maybe there was a misunderstanding.
I think we just intended to verbally discuss, you know,
Okay.
the real outcome measure is plasma GAA. And so I think we wanted to make that connection between if there were a trial for GAMT, they would not measure dry blood spots, they would measure plasma. And is there a lot of debate around the proper manner in which to do that? Do we need to establish considerations for how to collect that?
No, that's a fine. Yeah, so again, as Heidi said, when you do a clinical trial and you have an outcome, an end point is called in the clinical trial, which is a biomarker, it's very important to have a consistent way to collect the sample and make sure that if you see a variation,
she can come listen.
if you see variability, the slides disappeared. But you need to make sure that if you see changes in the biomarker, the changes are related to the treatment that the patient that is receiving, and it's not due to other factors. What are the factors that can affect variability in the measurement of this biomarker? Well, there are several, like at the time of collection. Is there a variation during the day in the concentration of the biomarker? How is the medication that the patient is receiving? Is that affecting the concentration? Clearly, is it affecting, but how long before or after the medication should we collect the sample? Is the diet, so is the meal, affecting the biomarker as well? So those are the things that we wanted to address with this study. There are some other factors that can affect the concentration, like the collection tube. If you collect is serum versus plasma different, or are they performing correctly, equally, is the storage temperature. How do we need, which temperature do we need to collect the blood? How soon before, after the collection of whole blood, does the plasma need to be separated? These are other analytical issues, and we do have an answer for those issues. We have done studies. There are studies published and studies that each of us have done in our laboratories, and we can control those variables. But the variable related to perhaps diurnal variation or fasting and so on, those are things that we don't have a good understanding yet. So in order to do this, we need we thought that we needed to do a study, and the study involves multiple measurement on the same day. So measuring a plasma, having a family bring in a child, a patient,
Right.
it might not be very practical. So we thought that we could start by using a blood spot, and the collection of the blood spot can be done at home. And once the blood spots are dried, then they can be shipped, they can be mailed, and to the laboratory that is going to perform the testing. So what we the study involves the enrollment of 10 patients with GAM deficiency, which patients who are receiving creatine and ornithine supplements, so patients who are on treatment. The sample will be blood collected by finger prick. The families will be given a lancet to prick the finger and the filter paper, and to spot the blood. The blood, then the filter paper with the blood spotted needs to be dry, completely dried before it's mailed. Typically, it will take probably 4 to 6 hours to dry. If it's dried overnight, it's even better. How many times how many collection in a day do we need for this study? Well, first of all, the study will be 2 weeks long, and we are asking to collect the samples on 2 weekdays and 2 weekend days over 2 weeks. So basically, you select the day that it's the best, and 1 weekday on week 1, 1 weekday on week 2, 1 weekend day on week 1, and 1 weekend day on week 2. There will be 6 collections per day, and let me see if I can, I don't know if you can see my pointer, but the first collection is in the morning before breakfast and before any medication or supplements are given. Then after 30-60 minutes after breakfast, there will be a second collection. Then 1 collection before lunch, and then 3 to 4 hours after lunch, and then again before dinner, and then before bedtime. That will be the last collection. That we called the last collection optional. We know that it's a lot of finger pricks for a day. So we would like to have that collection. It would be very helpful, but we understand if it's going to be, if it's not possible to do that. So that's the study. What do the family, what are we going to measure? So the the blood spot will be sent to Dr. Schulze lab, and where he's going to measure guanidinoacetate and creatine, and arginine and ornithine as well. Then the families who participate to this study will sign a consent form, and we are asking also to document, and Dr. Schulze is preparing a form, document the date and time of blood collection. This should be documented on the filter paper as well. Date and time and the dose of the medications and the supplements, and then date, time, serving size and composition of meals or formula. Just to have an idea so that we can correlate the results to the content of lunch or dinner. I think this is it for the study. Andreas, do you have anything else?
No, you explained it very well. So the study may look a little bit comprehensive in terms of what we are asking for, and I think we are very well aware that it may not work to 100%. So that's still good, because until now we have basically no information. I think Heidi will show. So we have two presentations, right, that show a little bit why we are doing that. The only thing I want to, by the way, I forgot to say where I am. I'm at the Kids in Toronto in Canada. So, but about the significance or the importance why we decided we want to do this, we are basing our treatment decisions mainly on guanidinoacetate concentrations. And we don't know enough about how good this information is. It's the best we have. That is why we do that. But I think it is time to understand better how we can interpret guanidinoacetate results that drawn at different time points, because everyone in the world does it a little bit different. And we really don't consider this aspect right now. Perhaps we don't have to, but that's what we would need to know. So that, I think, is why it really makes sense to do this. Also, one more comment about the format of the study. I decided not to include medical teams in this, where the patients are. That would have made it a bit easier in terms of getting even more comprehensive information about the participating children, patients, and families. However, from the logistics perspective, that becomes very, very laborious, because on basically needs ethics approvals from every participating site. That is a really big undertaking. That's why we decided, and with the help of ACD, I think we can do that we just do this format, what Marzia what Dr. Pasquali just presented. In terms of the finger pricks, some of the parents may know how to do this, others may not. And there, I think, are two ways to learn that. One is we will provide a video that we had produced, an educational video that we had produced for our families with patients with phenylketonuria. They have to do those finger pricks basically every week. That is one thing. And the other thing is what I would encourage you to do if you concerned, afraid of doing that, you have never done this before, I would think you should go to your medical care team and ask them to help you, to show this to you, so a nurse can tell you, can show you how this is done. So yeah, that's perhaps my comments.
Okay, I think, Colleen, let's pull up the recordings from Karine and Tony, and then we will come back to the group for some wrap up.
Okay, give me just a second, Heidi. I'll get that shared. Is everybody seeing my screen correctly?
Yes.
Thank you.
Thanks for having me here today. Thank you everyone for organising this. So, as you said, I work as a GP here in Australia, in Sydney. I have a daughter diagnosed at 5. She's now nearly 12, and interestingly, she has a very mild phenotype. At diagnosis, you can see her readings are classic GAMT, and the MRI showed she had very little creatine in her brain, so that's why she has a mild phenotype, I'm not really sure. So we're talking about monitoring GAA. When is the best time to measure it? We need to know how it fluctuates during the day. Do you measure it just before we give some ornithine, or do we wait for a lower trough level to occur in the ornithine levels? If GAA can't be metabolized, which obviously can't in GAMT, that's the problem. It has to be excreted. So what things affect this? Like urine acidity, does protein or amino acids affect it, fluid? Because they're also important, I think, in not just looking at ornithine. And what is the half-life of GAA? So if we developed a miracle drug that inhibits AGAT, how quickly would you see that effect in a blood test? So what I did, I collated a lot of my daughter's blood test results. Bloods were collected, over the years, and I've collated all those down to get this data. And obviously, it's quite limited because she's, done over many years. We're not controlling for any other factors. It's just done quite randomly. So here from this image here, you can see because we collected blood at various times, the profile of creatine, it matches the normal pharmacokinetics you'd see with the drug. So when you have a dose here at the beginning, you get a steep rise and a gradual decline. And it's way above the normal range. So creatine lasts for a long time, it builds up in the body, and we can safely be above that normal range most of the time. For ornithine, it's quite different. It still follows the same curve, the pharmacokinetic response, but you can see it drops down quite quickly. So after about 3 hours, the level of ornithine in the blood is probably not high enough to really be inhibiting AGAT. So, you can see people who are dosing maybe just 3 times a day, every 8 hours, you've got several hours where you're really not doing anything to inhibit AGAT. I also looked at data and how does the GAA change after the timing of the dose, and obviously soon after the dose it's lower, and as more time goes by the GAA levels rise. I'm wondering if this is a dose response for that, whether GAA drops down quickly and then climbs back up. This is just me fitting a curve to it. We obviously need better data than what I've got. I looked at the effects of creatine on GAA as well as ornithine on GAA, and you can see they both, as plasma creatine is high or as ornithine is high, you'll get lower levels of plasma GAA. Now, the problem here is, of course, you give creatine and ornithine at the same time, so they're correlated purely because they're both given at the same time. So if you look at plasma creatine, plasma ornithine, that effect we see with creatine at lowering GAA could purely be coincidence because we're giving it at the same time as the ornithine. We don't know. How does GAA vary during the day? This is just a collection of the data over a day. You'll see you've got some very high levels in the morning. It drops down during the day. If I show you when my daughter has her doses every 4 hours, see that morning dose at 7 a.m. Still we get that high reading there. Then I realised this data up the top here is from the night before where she had missed her morning dose. If we exclude that, now that looks like more what we'd expect and may give a curve of the GAA varies like this during the day. Again, we probably need better data, but it matches with the previous speaker how it can get quite big fluctuations especially when doses are skipped. I also looked at the effect of amino acids on guanidinoacetate acetate, and the top two graphs you can see, one looking at GAA versus arginine, the second is GAA versus glycine, and you can see that even over a very narrow range of arginine, we've got a huge change in plasma GAA, same with glycine. But interestingly, some of the amino acids, especially I found the essential amino acids, there was a fairly strong correlation at how the higher you have these other amino acids, the lower you get the plasma GAA. So thank you very much for listening to my talk.
Give me just a moment to get PAReNts talk queued up for us.
Hi, everyone, and thank you so much for the opportunity to share our story at the symposium. So we have a 4-year-old little boy. His name is Mias. He was diagnosed at 19 months old. And in South Africa, it was a real challenge to find a laboratory that was willing and capable to analyze guanidinoacetic acid in the plasma. So we had to take it upon ourselves. Luckily, I come from a scientific background, having worked in many labs. And I was able to connect with old colleagues of mine from the university who allowed me to come into the lab and actually analyze Mias's plasma myself. So just to give you an idea of where we started, initially we had Mias on a protein-restricted diet, and he was obviously getting creatine, ornithine, and sodium benzoate. We tried to spread this out throughout the day with 5 doses, with the 3 main doses, which has all 3 of the supplements, and then the 2 blue doses I kind of see as top-up doses with just ornithine and sodium benzoate. So when I collect a plasma sample for analysis, I try to always be consistent with the time of day that I do it, so that I can always compare apples with apples. And so we've chosen 12 p.m. for practical reasons to collect the sample at 12 p.m. right before his first, or rather his second big dose of creatine, ornithine, and sodium benzoate of the day. So here you can see some of the results. It started around 5th of September, and you can see we're pretty happy with Mias's results. It's all below 5, 4.4, 4.7, 3.7, 4.3, and 3.6. So yeah, super happy in general with where we are at. And then the creatine, it started slightly lower. Whether it's too low, I'm not sure, but we did end up increasing the creatine dose, and we could see that in the bloods done afterwards. Another thing was we lifted the protein restriction from when we started, and definitely we did not see any change in the guanidinoacetic acid levels, at least that time of day, even when we lifted and increased the protein intake. So at this point, Mias has no restriction on protein intake. So earlier this year, he had a lymph infection. It was quite severe. We had to have blood tests taken initially to figure out what was going on. And I asked the nurse to please take an additional sample while we have to stick a needle in his arm, get another sample so we can analyze it in the lab for the guanidinoacetic acid. So this allowed me to kind of get a little bit more of a scope of where we are. And the initial sample was at 4 p.m. right before the top-up dose, and we were really happy with the results with the guanidinoacetic acid at 2.8. So about 10 days later, he had to go under anesthesia so that they could remove the lymph, and he had to be fasting. So we had to skip this dose completely. And at around 3 p.m., he was under anesthesia. And I asked him to take a sample while he was in theater. And this sample's guanidinoacetic acid was 6 micromoles per liter. So you can see when you miss this dose, it does tend to creep. And then a month later, I did my normal checkup analysis at the normal time, and just to make sure, and I saw that it was 3.6, and super happy with that result. So this just shows you how the guanidinoacetic acid can increase if your doses aren't spread ideally, or if you were to miss a dose that you usually have. And I think this is kind of a field that we're not quite sure yet, what the implications are, what time of the day should the doses be, could it be even better than what we are seeing now, things like that. So yes, we have a lot of questions, but obviously sample handling, like I said now, the sample timing and also the frequency, how often are we supposed to measure the guanidinoacetic acid? And then just practical questions like how long after taking the supplements did sufficient absorption take place? I'm thinking now of when Mias has the stomach bug and he vomits after the supplements. I tend to be quite anxious whether it is being absorbed or not. And if it was enough time, and then factors affecting absorption, are there certain foods that can affect absorption, sleeping late or staying up late, should I wake him up at 6 so that he can take his dose, or can he sleep a bit late? Does it have an effect? Larger doses with a lower frequency throughout the day versus smaller doses and a higher frequency. I think everybody's got that question. And then increases in guanidinoacetic acid, if it does increase, how long does it take to lower it back down again? So for us to be able to address these questions, first of all, it would be ideal to have an easier sampling method, especially with the little ones, and then also an accurate and precise measurement with low cost and simple method. So that would be the ideal. Thank you.
That's great. Thank you, Karen. So I think let's go back to some questions for Dr. Schulze that may be perhaps on people's minds. How many
Before you start, Heidi, before you start, I want to make a comment here. And this is, I really want to applaud Karen and Tony for what you did. I mean, it is amazing. Both of you did something that we as the scientists should do or wanted to do. So I can tell you many of those questions were in our minds already for some time. When I opened my research laboratory at the kids, I had one question, and that was to test whether high dose, peak doses given are better or worse than giving it frequently spread over the day. I haven't been able to answer this question. I wanted to do this in mouse models or not in patients, but we haven't been able to really answer this question. But it is a great question. The other comment I want to make is we have to take all of this a little bit with a bit of caution, because we are basing everything on the plasma GAA levels. But what matters is the GAA in the brain. And for that, we have basically no information. So how much does affecting the GAA fluctuation has an impact on our patients' outcomes and how they are doing? We don't know. We have only very few studies that have been able to quantify guanidino acetate in the brain, and not related to dosing or anything. So we really don't know that. The best we can get right now is better understanding what we see in the blood. That would be a first step.
Yeah, maybe I also can make a comment now with regard to importance for a clinical trial. I have a patient who is on treatment with diet and with creatine and with ornithine, and who usually has levels, guanidino acetate levels between 3 and 4. But sometimes they are higher, they are 5 or 6. So I don't know, is it because the patient doesn't take their supplement, or is it because they do the blood work at different times? So we don't know. And the project that Marzia and Andreas are proposing is exactly for finding out whether these fluctuations that we often observe are due to treatment problems, or are just due to different timings of the blood draw. In a clinical trial, it will be very important to have a very steady and standardized setting, because we will have to assess in a clinical trial how effective is the treatment in reducing the guanidino acetate in the blood. So if somebody has a guanidino acetate of, let's say, 6 at the beginning of the trial, because they are taking all their diets and all their supplements, and then we introduce the treatment, and then upon the treatment, the level goes down to 3, for example, we still don't know, is it because of the treatment, or is it just because the blood has been drawn at different times in relation to the time when they take the supplement and when they have the treatment. So so we need to have a very solid information about when is it best to take the blood, and what would be differences in a clinical trial that would make significance. Yeah, that was my comment on the importance of the project that we're doing now.
So I'm just going to add notes to these slides as we go and capture kind of our conversation. And one aspect to think of, and I think Audrey will have an opinion here, is there are many things that need to be done, and this study will be a really important step, and we'll learn a lot from it. But I think looking down the road from this, we will begin to understand the impacts of these variables that we're trying to account for, such as the timing of when the blood is taken, the diet, the food, etc. And I wanted to point out to the families on the call
Do I have it with bread?
whose children have CTD, that Dr. Schulze is measuring creatine. And I do think that it's very interesting to see the fluctuation of the creatine after the dose as well. But then how does the plasma GAA, plasma to dry blood spot GAA relate? So how closely is this in sync? and Dr. Schulze and others could weigh in here. Is there a future trial to establish that connection down the road? And then we're talking about a biomarker. How can we say that these changes in guanidino acetate that we've said are important to follow in a clinical trial and observe maintained maybe when you go off of the supplements and you've had a gene therapy, or improve because that's what we think will happen with something that blocks AGAT or whatever? How can we say that those are definitely of benefit? And that would be some type of study, a natural history study, or an intervention and a natural history during that time, correlating cognitive outcomes with the GAA. And then if we find that this is strong, perhaps we could have dry blood spot routine monitoring instead of having to have plasma collected, which would be less invasive for our children and probably more affordable, and we could have performed more frequently. And then perhaps a dosing study is appropriate, as we talked about with PAReNts' experience, how the dosing impacts the level, and is it that overall Mias gets a better level because of such frequent dosing, or these are the question marks. Audrey, what do you think that this looks like for GAMT?
I just want to clarify, for dosing, you're talking about frequency of dose, not so much amount of dose. Yeah.
Yeah.
Yeah. Which is maybe avoiding the harder question. So, I mean, the first thing I'll say about any, cognitive behavioral, outcomes for GAMT is that we need to document them in the natural history. So we have no idea what the variability is. What the variability is over, time, from birth through the lifespan, right, in GAMT, and we have no idea how variable they are between patients. I think we have ideas from just anecdotes that there's significant variability, and maybe there's genotype and other factors that play into it, but clearly it seems to be early treatment is a major factor. So, if we were going to study these things, we would have to be accounting for those variables very, very, importantly. So again, first starting with natural history, and then tracking it over time. And I'm assuming we're only talking about whether the intervention has an impact in the long term, right? And so for that, I mean, part of why the outcome measures are the same for the conditions is because no matter what, I think we think that things like adaptive functioning, the things that were chosen, core outcomes would be important, but we can't predict how we would put cognitive outcomes into a study until we know more about the natural history. I'll just keep saying that.
And Karen, your comments were so good here, and I didn't capture them all, but I think you raised a really good one that's on everyone's mind, is the impact of diet restrictions. And certainly, and this meeting is not meant to be medical advice. It's definitely something that if you leave feeling, what am I doing versus this, share the recording with your doctor and let them consider these things with you. But certainly Karen's talk and Tony's both did not point strongly towards aggressive diet being the key to their success. But that I know that's not always what everyone's told, and it's not always what's in the papers. And are we to the point where now we maybe reconsider, because when sometimes we saw that improvement with the aggressive diet, some of these other factors that now we're looking at controlling for had not been controlled for, and it just leads us to, we need to know more? Or how do you feel about that, Dr. Stockler?
Well, I think the most important endpoint is to have the guanidino acetate as low as possible. If the lowest level is, that has been observed upon diet, is also achieved without diet, as we saw in that case, I think it's fine. But if the diet still would help to further lower the guanidino acetate levels, I think diet also has a place. I think it all depends on the entire picture. I also wanted to make a comment on the question, well, is guanidino acetate important for cognitive outcomes? I think what we know already now is, yes, the lowering of the guanidino acetate is very important for cognitive outcomes. And we know that from historic data from patients with GAMT deficiency who have only been treated with creatine and not with diet or ornithine to reduce the guanidino acetate levels. So, and these patients do have some response in terms of seizures or in terms of neurological outcomes, but these are all patients who have a very poor cognitive outcome. So I think we know that guanidino acetate, tackling the guanidino acetate levels in the blood is important, and I think there's no question about that. The question, of course, however, is how low do the guanidino acetate levels have to be in order to have an ideal outcome? And then I think that's something that we still don't know. And this will also be hampered by the fact that, as Dr. Schulze mentioned, what we're measuring in the blood is not representative for what happens in the brain, because the brain is a separate compartment. And guanidino acetate levels in the brain are at least partially independent from the levels in the blood. So if we have, let's say, even normal levels of guanidino acetate in the blood, it still could be that the levels are higher than normal in the brain. So there's still a lot of research to understand, but the overall message is, I think that low guanidino acetate is very important for cognitive outcomes.
Dr. Schulze?
Sorry, I need to raise my hand because I have to leave. I'm in service and we have handover now. But I want to briefly comment on the questions that have been put in the chat. One is, should the GAA level be below 5? That's kind of what we recommend, based on just the observation that in most cases, if it is below 5, then the seizures stop. But that's more or less all we know, right? It is really an empiric recommendation, but it looks like if it is below that level, it's good. I know about patients with a level of 8 doing very well. So I don't think one has to be scared if the level is a little bit higher, but everything is going very well. But again, we don't know much. The other thing is whether guanidino acetate is kind of similar in plasma, similar like HbA1c. No, not really. So the fluctuation in plasma is much faster. HbA1c is relatively stable. So if you get a level, you can say something about the blood glucose levels over the last couple of days. You cannot do this with GAA. It is just, it fluctuates, and PAReNts has shown this very well. Even if you stop, if you're not giving one dose, it seems that GAA goes already up. And the last thing is the carriers. So, and the question is, do they have elevated GAA levels? Most likely they may have some elevated levels. Does this matter? I mean, I would give a very pragmatic answer, and that is all of the parents of GAMT patients are carriers. We haven't done a study how you are doing. I'm sorry, I don't want to be personal here, but my impression is you are doing very well overall, you know. So this is why my answer would be, even if it is slightly elevated, we don't have any reason to believe that this has an impact on intellectual, cognitive, adaptive behavior. So that's my answer.
The last question is, do you think there's a topped out dose for ornithine as the kids
yes.
grow?
Yeah, so recommendation for children is 800 milligrams per kilo. This is quite high, and some are really not struggling with this. But we do know that as higher as better. Often children are getting 400. And you know, the way I do this, if I am contacted by a family and they say, okay, we have problems here, there are still seizures, there is this and that, then I would ask, okay, what's the guanidino acetate level? And if the level is let's say 6, 7, 8 or so, I would say perhaps try to increase ornithine to get it lower and see whether the seizure disorder, the seizures stop. And that is also what Dr. Stöckler already mentioned in terms of the diet. So when Karim stopped the diet and didn't see a difference, that's not a surprise, because this diet was not very strict. It was 1.7 grams of protein. And by that, you are not really reducing arginine intake much. If you want to do an efficient diet, it has to be a much stricter restriction and the addition of medical protein. Otherwise, it doesn't work. So a little bit diet, I don't think that this makes a difference.
I think you said your current recommendation is around 400 milligrams per kilogram per day of ornithine?
No, 800.
800, okay.
Yeah, you cannot do this in adults, right? So the question about top out is, all of our recommendations are per kilogram, and that is appropriate for a person perhaps up to 30 kilograms body weight or 40. If it gets higher, one has to use a dose that is more related to the body surface, if one wants to kind of get an equivalent dose. But is there a top out? Not really. The
Yeah,
only
I
thing,
think,
okay.
I
Yeah,
think that with Andreas' study, we also might be able to answer this question better, taking that example that Andreas described, somebody who is not ideally responding to the treatment, and then asking to give higher doses of ornithine. The study might provide information whether maybe the doses can even be the same, or maybe just slightly elevated, but spread better over the day, so that patient doesn't take the ornithine in 3 doses, but maybe in 6 doses. So the levels could be, you know, adjusted accordingly. So that's one of the potentials of the study, and one of the answers, hopefully, that we can get.
So one of the things I think I heard or inferred is that perhaps the ideal diet and even dosing for patients could be unique to each individual. And that's something where, you know, we have a lot of families that they get the initial diagnosis and they are put on a very restrictive diet, for example, and then they join the support group and they hear a mix of stories. They hear stories of, oh, we've continued to be very, you know, diligent, and we're achieving a level of a GAA of 5. And another family who is completely relaxed with the diet and is achieving a level of 4. And my suspicion is that this kind of is the medical approach, is to begin with all of the restrictions and try to achieve the very best GAA, and then allow small changes and see if the GAA remains, or if you see it increase, you go backwards. Is that kind of how you approach things, Dr. Stockler?
Yeah, and also to standardize the timing of the measurement, right? Because when you speak about levels 4 and 5, that patient could always have a level at 4 if the blood was taken always at a certain time after the ornithine ingestion, and the level could rise to 6 even if, you know, many hours or just before the next doses of the ornithine ingestion. So I think we really need to understand what's the best time to measure the guanidino acetate levels in terms of daily diet and daily supplement intake, and then to decide, you know, a standardized time and say, well, all patients should have their blood draws, let's say 1 hour before or 1 hour after or 2 hours after ornithine and creatine supplement. So I think we should really know about it, and then we can talk about, you know, about optimizing the level of the guanidino acetate levels in the individual patients by titrating their supplements and plus minus diet.
Great. Does anyone have any additional questions? I think every question that comes up points us to our study that we're doing, and the great things that we will learn and apply. So I think we really touched on all of the questions, and I was gonna raise the question with Dr. Schulze. When does the study begin? I can tell you what I know is that ACD will be putting out recruitment materials. We've prepared all of that, and it's been reviewed by Dr. Schulze's REB Ethics Review Committee. And so we will be able to like announce this and reach out proactively. And if you are interested, you'll fill out a form, and then you'll go through the typical participation in a study consent with Dr. Schulze's study coordinator. And then we would be sending you all of the materials, and you would pick the right time for your family to do this. And I just want to add that I know that this won't be right for everyone's child, and that you shouldn't feel bad. But if it is something that your child might tolerate and you're able to participate, I think it would be wonderful. My child diagnosed from birth absolutely hates getting poked, and he should be the easiest, right? And Samantha, who's 22 and been poked for 16 years, doesn't care anymore. So I'll get at least one kid in this study, and it's a very personal question whether or not you participate. So please just feel respected that your choice is your choice, and never pressured. But hopefully everyone leaves this meeting feeling like they understand the benefit to a clinical trial in the future, and to our daily care and questions that we all have in caring for our kids with GAMT. And before we leave, are there any other questions or any ideas that maybe Dr. Thurm or Stockler or Pasquali have that they want to raise? Okay. All right. Well, with that, we'll say have a great weekend wherever you are, and we'll stay in communication about this. And thank you very, very much for participating.